Okie dokie. Response to the first one was really good. Thankfully, lots of really good comment and engagement. So we're going to come back and look at more ideas for change. But this time what we're going to do is change it. So last time I had it sorted by most reactions, which I guess will result in things being polarized a little bit. We're just going to go random for this one. Maybe do another half an hour just to have a look, because we'll get some truly weird and wonderful, I imagine. Okay, let's start. Stop telehealth consultations. They served a purpose during COVID but are detrimental to good care. There have been several cases noted in misdiagnosis due to the inability of the doctor. I think this is a bit of a sledgehammer approach. Are there circumstances in which telehealth consultations might be the most appropriate and efficient thing? Yeah, I can think of many. Anything where you might be extending a medication, or maybe changing a medication that someone's on, or just following up on some aspect of care. Physical examination is just a tool that is part of a clinician's repertoire and can be done inappropriately or pointlessly just as much as it can be done appropriately. So can physical examination have utility? Yes, a lot of the time it absolutely will, particularly for an undifferentiated new patient. But it may be that the question you're asking doesn't require a physical examination. So I think telehealth will not only stay, but is the most appropriate type of consultation for many types of problem. Give us an expected time of treatment in A&E. My eye's hanging out, but if I have to wait 15 hours for treatment in A&E, I'd rather go home and come back. Sitting in A&E for hours is the worst, and you feel like you can't leave because you'll miss your turn, you can't even sleep. How about keeping me updated via the NHS app? Then I can leave or go and sit in a coffee shop and come back. I think part of the answer to that has to be that if you are able to go home and wait for 15 hours and then come back, you have to ask the question, should you be in A&E at all? Obviously in some cases you will, but a lot of the time it's pretty clear whether someone does have to be in A&E or they don't. The real problem with this is that emergency care is so unpredictable. So you might be able to say, well, the average waiting time is 8 hours, 9 hours, 10 hours. But the problem is if someone comes in that's more sick than you, we run by triage system. So we might say to you, it's 1 a.m, the waiting time to see a doctor might be 8 hours or whatever. It now gets to 9 a.m, but loads of people turned up that were sicker than you and got bumped in front of you. So it might get to 9 a.m. and you might not have been seen yet, and that's not a failure on anyone's part particularly. You've only got the resources that you've got. So it's not like you have a place in the queue as such. You do, but it's not guaranteeing that you'll be seen in a particular time. It's an ever-evolving, changing queue that is triaged by how unwell people are and who is carrying the most risk to life and limb. This is interesting. Stop paying GPs by the number of patients on their books. Pay GPs for each patient they actually see, which would incentivize GPs to see patients. Also, patients should make a small payment towards the cost of each appointment, and that would stop people booking unnecessary appointments. So there's two things here. To start with, charging people for appointments first. That is something that you could do, and some countries I believe do that. The problem is twofold. One is that you have to set up another system to oversee the administration of handling all of these payments that would be required and chasing people that haven't paid and processing payments and all of these things. So you have to create another system to manage it. The second problem, and this is what makes me uncomfortable, if the NHS is meant to be free at the point of use and you introduce a charge of any amount, it's going to disincentivize the most at-risk groups from coming to see their GP at all, because some people won't be able to manage the cost, or they will have better, more responsible things to spend that money on. And that means that, again, the most impoverished become the most affected by adverse health outcomes because they don't come and get seen. If they have cancer and other things, it progresses. If they have poor dental health, it gets worse, etc., etc. It's something you could do, but we would need to have a very serious national conversation about that and what support would be in place for people that can't afford it. And then by the time you've done all of that, you end up with a huge number of people who can't afford it anyway, so then nothing really changes. And then stop paying GPs by the number of patients on the books. Pay GPs for each patient they see. We've conflated the idea of the GP, I think, as a partnership, as a GP practice, which is what I assume they mean by number of patients on the books, and what a GP, that is an individual general practitioner doctor who is employed by a GP practice, is doing. So that's one thing. You could have a GP practice that has a very large number of patients on the books, but then only sees a small subset of them per day within safe limits. So you've got to be really careful that you're not going to tank the finances of all of these practices and send them under by doing this, because they've only got a fixed capacity. So if you make the number of patients they can see fixed for a fixed sum of money, then that will just favor massive practices that can employ masses of GPs, or assuming this extends to nurse practitioners or physician associates or anyone else you have employed. And the other thing is that the value of what GPs do, or a lot of the work that they do, is of course not simply related to seeing patients. That's just one thing that they do. They have to respond to letters, they have to train and supervise other members of staff, other GPs, and a lot of the time that won't involve directly seeing a patient in front of you. So I worry that this misses out. I worry that a mass-scale consultation with the public misses out a lot of specialist nuance. Progression of existing NHS staff. Allowing existing staff to train and to be nurses and doctors while continuing to work for the trust that they're working training for. We have a shortage of doctors and nurses. Certainly on the doctor side, that's sort of true, is not entirely true. For nurses, it's definitely true. For lots of staff already, they've built knowledge of medical diagnoses of interventions. They could quite easily be trained to be good doctors and nurses, but can't due to needing to work or having low GCSEs or whatever. So I guess the question is, again, partly, do we allow an apprenticeship in work type model of medical or nursing education? And I believe that these things have been started. The problem with this is that you're trying to deviate from the gold standard, is one thing. So if we are insisting that it takes, say, a medical student 5 years of full-time university education, or 4 years as a graduate by eliminating the summer holidays, there's an inherent assumption there that you shouldn't be working during that time, that you should be in class, in lectures, doing whatever. And I believe the way that the apprenticeship models work is that they actually spend the summer working in some sort of health capacity. So I don't think it's quite as simple as saying these people already have some amount of health knowledge and experience, therefore they should be able to keep working while they train as doctors or nurses. But the other thing is that I don't believe there is a lot of good quality evidence to suggest that such people would actually be more suitable to be doctors and nurses. I think it's one of those things that instinctively we would like to be correct, but you would need some really good quality, rigorous evidence to say someone that has worked as a nurse or has worked as a paramedic is more suitable or more capable of being trained as a doctor than someone else. And there are graduate entry schools you could look at, places like Warwick, that have run graduate entry only cohorts for a long time, but I don't believe the outcomes are significantly better for those who have worked in the health system and those that haven't over many studies. So it's an interesting idea, but I'm not sure the evidence actually bears out. The CPS should prosecute non-medics passing themselves off as qualified doctors. Oh, I see. Okay, this is about PAs. I do not think this is necessarily a PA specific problem. I think they are one example of people that could, I'm not saying do, but could fall into this problem. Nobody seems to have taken any action on this dangerous practice, not the GMC, not the police. There is a problem when you're working in the NHS of people, there's a lot of very ambiguous job titles, and practitioner is my least favourite one because it tells you nothing about the person that you're speaking to. A good job description or a good role introduction to me should include the base profession, so what it is that you're actually trained to do, and then nuance on top of that. But if I'm speaking to a referral or a service where I'm seeking referral advice or something, and I call rheumatology and they say, yes, you're on the phone with the rheumatology practitioner, I can't really do anything with that because that person may be someone who can medico-legally give me advice that I can act on. It may not be. This is a problem in the NHS in general, but obscure titles are a problem, and people obscuring their own titles is also obviously a massive problem. And so now I'm very careful, and people in general should be, when you're speaking to someone on the phone and you're not dead clear who they are and what their title is, you need to be asking them, who are you? What is your, name, role, title, something like GMC number, NMC number, etc. Create one daily payment rate for locums. Locums earn different amounts through the country ranging from £500 to £1,500 a day. I wouldn't have said £500 a day was a lot for a locum, to be honest. Reducing the rate would keep GPs or doctors in situ without having the temptation of extra earnings. Don't think that's true. If you lower and lower the rates, people simply aren't going to do them, especially because our marginal tax rates are very high. Like, using myself as an example, if I start doing lots of locums, me personally, it will push me very quickly in fact, probably after a few shifts, into the 40% tax bracket on those extra earnings on top of the salary I'm already earning. I've then got a student loan on top of that, so add another 9%. My marginal tax rate is nearly 50%. So unless you're going to make the locum rate very good in a high cost of living area, bearing in mind that I live close to London, it's simply not going to be worth it for me, and you are not going to get the extra pay, or you're not going to get the extra work from me. Sorry, because it's not worth it. Because medical activity is high risk, high intensity work. I would quite readily do something that I find easier and doesn't cause me any medico-legal risk than picking up that poorly paid medical work. You're not going to make this work for very highly skilled and mobile people. Progressive waiving of doctor and nurse higher education tuition fee repayment. It should be waived progressively to encourage staff retention, e.g. 3 years service, 1 year's fees waived, then 1 further year waived for every subsequent year of service. This is great. I love this. So it's saying that I, for example, have 4 years of student debt. So if I worked in the NHS for 7 years, 3 years continuous service for 1 year's fees, then 1 further year. Yeah, exactly. So if I did 7 years, it would take me up to, say, ST2, ST3 kind of level. That would wipe my tuition fees. I think that's a great idea, personally, because I agree it would encourage retention for this period. But doctors and nurses only, again, it's one of these things where if you're going to attach conditions and things to particular degrees, then you have to question how widely. Is that every health role? Is that entire public sector? Where are you going to draw the line? Oh, reform UKFP, more happy doctors. So this is about reforming the UK Foundation programme. So this is the system when doctors graduate from medical school, we essentially get randomised to a degree around the country. The way it works now, which is different to when I graduated, is that every graduating doctor is assigned a number by a computer, from 1 to, say, 10,000 or however many graduates there are, and then you preference inform, that is, you rank all of the different areas in the country you go to, and ideally you will be matched to something quite high up your list of preferences. But the problem is the way the algorithm has been designed is such that you either essentially get your first choice, in which case you're happy, or you get something very, very far down, like your 15th or 16th choice, as an artifact of the way the algorithm works. And to be honest, I should make a video about that anyway, because it's interesting the way they've chosen to do it. Yeah, there's another similar one here about reducing doctors' training pathways and shortening them, reducing rotation, giving graduates more control over where they go. This is all part of a larger discussion. Doctors are essentially captured into the NHS in a way that they provide relatively very cheap labour to every hospital in the country, because you're essentially matching every possible graduate against every possible open rota slot in the country, and doctors don't interview, they don't get screened, they just get randomly matched. And what that does is it ensures that hospitals and settings that would not be able to attract people under normal circumstances, or would not recruit and retain people, they automatically get doctors assigned for them, and those doctors don't have any say. They're just told this is where you're going. It's a bit like conscription. And we need a discussion about this, because what this does do is that it ensures every single hospital has access to doctors of a standardised quality, which is a good thing for the public, but it's obviously very, very bad for doctors' autonomy. And certainly for me, it generated a lot of resentment with the system very quickly, because you're spending a long time training and educating and upskilling people but then you're removing all autonomy from them very quickly and not recognizing them as individuals with all of that training and skill. Delayed discharges. To tackle delayed discharges, play Coldplay on a loop through speakers on all wards. Yes, Sarah. Yes, that will get people out so unimaginably quickly. Smartwatches for people, good or bad? Smartwatches for people are bad, but continuous glucose monitoring are good, which only some type 1 diabetics get because of the cost. So the NHS keeps quiet about because of the cost. Okay, this is a lot, but what he's getting at, an accurate blood pressure using upper arm cuff and continuous glucose monitoring and a smartwatch. So that's 3 devices. And will doctors go along with this? And some people die, but some go to hospital. Fine. I guess maybe something here about, do we give everyone in the community blood pressure monitors and continuous glucose monitors? Like, you could attach a Libra device to everyone and constantly be measuring people's blood glucose activity. I don't think we should do that, personally. I think there should be a clear need for it, given the cost of the devices and analysing all of the data. Just knowing everyone's blood glucose at all time is not going to be, to me, as useful as screening high-risk populations that are likely to suffer ill health. There's another one about training, pathways into NHS careers. Why do nurses now need to complete a degree to do a job that never required it? Because the evidence suggests that their patients are better off when we do. That's why. Take away the uni courses until higher levels of learning that would be a postgrad and a master's. I think we really run the risk here of devaluing nursing as an academic endeavour in its own right. There are a lot of people that think like this. Why do you need a degree to be a nurse? Why do you need university level education? Look, clearly the role has changed very significantly. The demands have changed. What nurses are doing has changed. And now there's a lot more, research nursing, specialist nursing. Like, you need to be clever, and you need to be taking those very clever people and educating them properly. And the way that we do that is via university for these kinds of academic disciplines. And nursing needs to be seen as an academic discipline, just like dietetics or speech and language therapy or medicine. It needs to be viewed in that way, in my opinion, so that we are training nurses properly and doing right by them, basically. GPs to have extra training in a specialism. Some patients wait on long waiting lists to see a consultant. It would make sense to give GPs 6 months of specialist training. And they've listed a load of things here. So this is interesting, actually, just from an academic perspective. So the first thing I want to say is that 6 months of specialist training in a specialty is nothing. It's like an unbelievable flash in the pan. That was my first response. But GPs with special interest do still exist. They have existed. I think they used to be called something else, but GP with special interest definitely is a thing, and there are all sorts of qualifications and certificates that GPs can do to upskill in particular areas. There's another one here. It came up last time about prostate cancer screening. Why can't the NHS screen males over 45-50 regularly for prostate cancer? The cost of a PSA test or MRI versus cost of treatment must be comparable to the tests. It's a great question, and I am pleased that people are thinking, that people in the public setting are thinking about this. How can we prevent or catch disease early? That's a great thing. The answer to this is that the PSA test is not reliable enough for screening. We don't have a screening test for community prostate cancer screening that would be reliable enough to start inviting people for MRI scans. There's a few relevant studies which were done by actually someone that we've had on the channel before, Viru Kasivisvanathan, who's a consultant urologist now. He did this series of studies. So one of which is called the Precision Trial, the other is Prime, his most recent trial. And this is all about how we investigate prostate cancer. And he's shown that MRI, as part of the workup for prostate cancer, was superior to biopsy. So people are thinking about how we solve these problems. And then they've recently shown with Prime that biparametric MRI, I can't remember, forgive me Viru, is either non-inferior or superior to multiparametric MRI for finding prostate cancer. So all of this is to say that we're getting way better at the imaging side of things and actually detecting prostate cancer when we suspect someone has it, but we still have a lot of work to do if we're going to work towards screening, because we have not worked out how to do community screening properly for prostate cancer if we are going to do it. And then last one, reduce A-level requirements to do a medical degree as a doctor. We hire too many doctors from overseas. Controversial. Many young people of more than adequate intelligence could train as doctors and surgeons but fail to get the grades. Reduce the entry requirements to universities to improve the training pool. Again, two things. Are A-levels the best selector of who is going to make a good doctor? That's going to be very up in the air. What you need to do is know that people are going to make it out the other end of the degree, because the worst possible outcome is that they do 2, 3, 4 years, they have a load of money invested into them, and then they don't graduate and the system doesn't get a doctor. So you need some way of predicting success on the medical school course, and ideally in postgraduate exams as well. Are A-levels the best way to do that? Not necessarily. We use other forms of selection as well. We use the interviews, we require work experience, we use an aptitude test. All of these things are sort of proxy markers of various quality of predictors for success. The reality is that medical school places are already oversubscribed, and so therefore there is not a need right now to reduce the A-level requirements, or rather nothing would really change as far as the system is concerned if we did. I don't really know what the A-level requirement thing has to do with hiring international doctors, because we're hiring international doctors to plug staffing gaps that are well beyond medical school, and I don't think the two things are really linked. What this person presumably wants is for us to open lots more medical school places as well, which we do need to do, but it won't make any difference if that expansion in medical school training is not matched by postgraduate training places in all of the different specialties where we need doctors, particularly in the general medical specialties. So all of that is to say that A-level requirements are kind of one very, very, very small piece of a puzzle, and even if you start fiddling around with A-level requirements, it's not going to change anything to do with the workforce, really. You're still not going to have doctors in the places that you need them. They'll just have different A-levels. But thanks very much, guys. That's the second one. Can always do more if you find it interesting, or if you want me to discuss particular issues in more detail, which some of you did in the last one. But thanks very much. Take care. Bye-bye.